perhaps take some questions. In fact, what I'm going to do very briefly, because I think it'll be fun, is I'm going to just show you something on Accurix, because this might go horribly wrong. But what I want to do is, here we go. Oh, it won't let me do it. Never mind. I wanted to show you Accurix, but it really won't let me do it. Steve, carry on. That's fine.
Mike, thank you very much indeed. Exceptional again. We've actually had quite a few questions come in for you. Well, Mel will go through the questions, but yeah, I have to thank you because it was, again, bang on the money. And the message, of course, is if you don't know your PCN, you're not doing your job right, I think. So, Mel, do you want to start with the questions?
Yeah, thank you very much for that, Mike. The first question we have is from Peter, and it's, we believe that sexual health funding is changing and going back to primary care. Can you provide any information on this?
So I know that it's something that they're discussing, but I've checked fairly recently, and there's nothing written contractually yet. The idea is that if anyone hasn't figured out that Public Health England is on the chopping block, then they're going to shoulder the blame for COVID. They're already teeing up at Public Health England to do so, and all the Public Health England contracts that used to be run by the PCT are going to be handed back to PCNs. God, all these three-letter acronyms, three initials. It's there. So there is some talk around sexual health, smoking, health checks, all that sort of public healthy stuff going to PCNs via NHS England. However, it's probably it's not going to be in this calendar year. But one thing I've learned about NHS England is that they tend to make announcements at extremely short notice, usually via the mainstream media. But I would anticipate probably April 21 we'll have more idea of when that's the details of that. You can guarantee it's going to be underfunded though.
Fab. A question from Pete Royal. What are the top 3 priority areas where you need to succeed as a PCN? Do you have 3 areas? Yeah.
So the problem with it's a very difficult question to answer succinctly. So there are 3. The 3 areas that I would suggest that are topical at the moment is frail elderly monitoring. Now, what I mean by that is that we've been given a huge bit of our contract to monitor care homes and frail elderly people within those care homes. And we're being asked to do an awful lot of assessments and a lot of planning with very little resource comparatively. But it's enough to make it worth our while. So I think that the only way we're going to do that is working with partners and working with the other practices in the PCN and trying to think of innovative ways to gather and garner that information. So that'd be one. The second thing we need to do is we need to somehow find some leadership within primary care, because the problem is that all the people who are half decent leaders will either be sucked up to the ICS, or people have realized they're crap and they never should have been leaders, or they're going to go to the private sector. And what we're seeing at the moment is that I'm now expected, I'm a clinical director of my PCN, and I'm very experienced. I'm not shy to say that I'm very experienced in this, and I'm finding it really tough. And I'm finding it really tough to find a way to get people infused, come up with new innovations, and we need some support in either providing the training for that, or providing some support in writing business cases, providing some support in providing, proofs of concept. So let me give you an idea of that. Is that if I've got a really good idea about how we can make a saving and improve safety or improve quality in the service locally, getting it from here onto a piece of paper in a language that someone who's paying for that understands requires somebody. Now, I can just about do that, but that skill doesn't really exist in primary care because we're trained to be doctors. We're not trained to do that. The third thing I would say is that there is something about sustainability. So yes, we're giving all these sort of crumbs from the table of NHS England about how to keep PCNs alive, but there's this sort of underlying tone of you need to start finding projects to keep yourselves alive. So you need to start looking aside from what we're giving you for new sources of income, new contracts. Think about what work you can take from a hospital, deliver in primary care. So they're the three areas that I would pick, and there is more detail around that.
That's a really great answer, Mike. We've got questions coming in fast and furiously, so we'll whiz on. The next question is, any specific plans on flu vaccinations, either as a practice or a PCN?
Yeah, first of all, it's nice to know what the flu plans are from NHS England. So I found out at the same time as everyone else that the over 50s will be included in the flu jabs this year. So what that means for us is that we've got about 20,000 patients in our practice. We've got about 30,000 in our PCN. And it means that our eligible flu population is about a third of that now. So we're going to have to probably vaccinate about 10,000 people for flu this year. Add into the fact that there's a shortage of flu jabs, add into the fact that actually logistically that offers a challenge because we want less footfall in the building, but all of a sudden we're saying we need 10,000. So we're basically, the only way we're going to deliver this is as a PCN, that's for sure. And we're going to have to do almost like an event management thing. So we've got a project manager in to do ours, and our project manager specializes in events rather than healthcare, because the healthcare bit I know. What I don't know is how to coordinate 10,000 people in a safe way through social distancing in a way that they're going to be protected from the elements, access to parking, traffic. And actually, he's already been quite good. So he's already changed my initial flu plan. So we've now rented the top floor of a multi-story car park. We're putting marquees on it and people are driving around. And he's done some fantastic things around how we're going to get cold chain storage, around how we're going to prioritize who comes where. He's got booking slots that people come between 10 and 11, 11 and 12. He's got barcodes for people that links for their notes. I mean, it's total change on previous years. It's going to be and this is a dress rehearsal for the big vaccine that's coming next year, which is the COVID vaccine, which once again will in itself present new challenges. Any practice that thinks that they're going to do this the same way they've done it previous years by just opening a back door and getting everyone in and out and jabbing them is deluded. So every practice I've spoken to in Harts Valley is doing this as a PCN. Every practice that's half decent in England that I've spoken to, and I do have a big network that I've got on social media and WhatsApp, they're doing it via PCNs. The problem is that where are we going to get that resource from? So the CCG has given us a little bit of extra cash to do that. The problem is this year is the community pharmacies, they're going to be able to do them, but they can't do them outside their own premises. So the independent pharmacies are screwed this year. So our pharmacy next door, which is a very small pharmacy, they've got one in, one out in terms of their shop. They would traditionally do this. They've already said they can either choose to dispense medications or give people a flu jab, but they can't do both at the same time. So they're going to do a load of that. The challenge comes from us is that traditionally we've always been in competition with the community pharmacists for flu. That's the thing that no one will say. It's a money thing. They're taking money off us if we do it, if they do it, and we're taking money off them if they do it. How do we have that conversation to collaborate and do it together? There's a massive workforce there that we can use. They've probably ordered in excess of vaccines that they need to do it. We've got a shortage of vaccines. If we could find a way to work together, there's an obvious solution there. But it's a work in progress. The short answer is it's going to be different this year and it's going to be big.
Yeah, as Felicia said, we've just had a question come in from Martin, who has strong links into community pharmacy because he is a pharmacist. he states that pharmacists have become more skilled over the last few years and can take on some of the routine tasks that you would have, like medicines review and GP, the vaccines and BP assessments of inhalers, etc. Do you see this as a welcome extension, Mike, at this moment in time? You did mention competition. Do you see more collaboration?
So the point is, what it boils down to is that we're small businesses. We're no different. They're no different. And look, I'm not sort of aggressive in the way that I do it. But would I prefer patients to come to me than the local community pharmacist? Of course I do. I own this business. I don't want to give away business like that. I get paid per flu jab. So of course I want to do them myself. Actually, the you know, in terms of the community pharmacists, what we've got to do is talk about the role, which is massively valuable. So we've already employed 2 community pharmacists, clinical pharmacists in our PCN, and the businesses, which are not about the people. So I don't see there's much of a future in the short term of the businesses collaborating with GP practices unless they merge as businesses, because we're basically farming from the same place. We're fishing from the same pond. I totally get Martin's point. Not only are they good at flu vaccines, they're better than us. Community pharmacists can do a BP assessment, inhaler technique, and flu jab better than me. I'm crap at it. You should see me. I'm playing darts at the end of the road. I don't even know who I'm giving it to half the time. So they are better at it. I get that. And I've just read there that Martin said actually pharmacies would be able to do flu jabs outside the premises. That must be a change of this morning, because I was on the phone to the Deputy Director of NHS England yesterday. They've told me that hasn't changed, so I don't know quite where that's from. I don't know whether there's a nuance to that, but I know that they're not allowed to go to a car park like we are and give them, as per the current legislation. But once again, I may be corrected on that. As far as I'm aware, that was one of the biggest challenge on the webinars that I've had and we've had community pharmacists on the same webinar who have been sort of questioning that as well.
Fab. I've got a message here from, I think it's Gerald.
Yeah.
And he asks, how will GPs reach out to those in the population who are digitally excluded? Similarly, sorry, just hold on a sec. My assistant here is a bit useless.
So I can read that actually, Mel. I can read that exclusive with sensory and learning difficulties. So look, the point is that this isn't just one option for people. The traditional route will be there for those who don't want to use it. One thing I'd say is that digitally excluded, one thing I'd be stunned about is how small that population is. You know, our silver surfers are a massive population. You know, they're the biggest users of our online services, the 60 to 80-year-olds. Like I said, we had a 96-year-old who bought something off Amazon this morning just with ease, not even with instruction. It wasn't like a chore. He just said, okay, I'll buy it. And he said, yes, I've bought it now. It's arriving tomorrow. I'm a Prime member. So once again, first of all, I think that population is overstated in terms of its numbers, but we've still got the traditional method. So we look after 3 homes for people with learning disabilities. First thing I'd say is that a lot of them are iPad savvy. And you know, the thing about iPads is that they are very easy to use. Whoever's designed these tablets knew that. You know, I don't know if any of you have seen a sort of a toddler on an iPad. They seem to just know their way around it. They touch the screen. They're able to use it. It's been designed in such a clever way. I've been stunned that my daughter could use an iPad before she could formulate a sentence. I mean, let's just think of the impact of that. So once again, I do think that we need to be encouraging these. But having said that, those who've got profound sensory and learning difficulties, they're usually in some sort of care facility, and we're offering a different type of care for those. So rather than empowering the patient, we need to empower the people who look after those patients, so their carers and their relatives. So that stethoscope I showed you, I don't expect someone with sensory and learning difficulties to be using it, but the person looking after them or caring for them or their named carer, I would think would be reasonable for them to be able to use that.
Brilliant. Right, we're on to the next question, another one from Pete Royal. Will QUIP work streams be as much a priority for PCNs as the network contract?
No is the short answer, because you know, the problem is that it's not been done great, if I'm honest. It should be. It really should be. It is for me, because I see the longer term benefits of doing that. But you understand the mindset of most GPs is to deal with what's immediately in front of them. And that sort of second order and third order thinking is, for strategy and for contracts, is something that for doctors and for nurses, particularly for doctors, doesn't come easily. So it should do, but no, it won't be. It's all about the network contract, which when you look at it is one of the crappiest contracts I've ever seen. I commented to one of my colleagues this morning, how on earth did the British Medical Association pass this? And then not only pass it, but cite it as one of the biggest contractual victories ever. I'm waiting to see what they saw or whatever they were smoking at the time, because it really isn't as good as all that. Personally, I think it's a big threat, not only to general practice, but also to the whole primary care family, pharmacies, optometrists, sorry, dentists. I think it's a big threat. I've got worries, but we're going to have to deal what do what we're dealt with, actually. But short answer is no, it'll be the network contracts, I'm afraid.
No, that's great, thank you. And then we've got one question here. What kind of services do you see moving from acute to primary care? That's from Amarish.
Yeah, I mean, so where do you start, Amarish? You know, reasonably, it could be anything that doesn't require a specialist expensive hospital. So, you know, I could give you a list of about 50. Really, I used to be a medical director of an acute trust, and I used to say all the time, why does this need to be in a hospital? And there always used to be some answer of a what if or a whataboutery about it. But no, it's actually, it's just tradition and historic that the reasons that stuff is in hospital. So I would suggest that anything that involves an infusion could reasonably be done in a primary care. I think anything that reasonably involves getting monitoring could be done in primary care. I think that the skill sets that are nurse-led, why can't those nurses be employed in primary care rather than secondary care? If the only reason that's keeping them in the hospital is access to a specialist, if one thing we've learned in the last 6 months is access to a specialist doesn't have to be them physically with you. In fact, they're probably more accessible this way than they were when they were out in the ward seeing people. So once again, I think that it's not about what services moving from acute to primary care. I put a challenge there. I'd say, what service do you think need to stay in a hospital?
Yeah, that's a really good way to look at it, I think.
Yeah.
Yeah. Another question.
Regards PCNs, Mike, do you see procurement being centralised through PCNs of everyday equipment? I.e., you're hoarding behind that lovely screen all of that PPE. Do you see the PCNs doing all of the procurement from now on rather than it be practice-based?
We've already started in ours. We're buying all our flu jabs as a PCN. We're buying all of our PPE as a PCN. We're buying our minor surgical equipment as a PCN. I mean, to be honest, you know, PCNs have only been alive a year and we've already moved all that to them. The point is that the bigger you are, the more purchasing power you have. So, you know, why wouldn't we? In fact, I'll go one step further, Steve. I'd say groups of PCNs will be procuring stuff because actually you've got ready-made units to do it. And I'm already in talks with the St Albans and Harpenden primary care networks to talk about what we can buy next year, mainly flus, because we found flu a bit of a challenge, as we always do, but also other equipment going forward. So yeah, absolutely. It'll be groups of PCNs rather than individual PCNs. And groups of PCNs might then become, I don't know, PCTs, who knows? Well, no, then would have gone on. Then would have gone full circle, won't we?
So you're telling us actually you're really going to fund holding just now?
No, we can't call it fund holding. As James Kingland says, it's fund holding on steroids, Steve.
We've said this many times between the terms, haven't we? Right.
Mike, we've got a question in from Don Haynes, and his question is: there are concerns from PHE on indemnity, to his knowledge. That's the question. So,
on indemnity.
Yeah.
Don, are you there? Do you want to unmute and ask? You'll have to elaborate on that.
Sorry, do beg pardon. I mean, it's just a follow-on to the flu question, really.
Oh, specifically for flu?
Yes. Sorry, I didn't make that clear.
Yeah, no, sure. So there are several issues. One is that our indemnity, the Medical Defence Union, which underwrites the NHS programme, covers us for all core GMS work. And I have had confirmation last week that if everything we do is core GMS, then we are covered. I've also heard from the Care Quality Commission to get a second opinion on if we were to do this in a car park, would we need to register the top floor of a car park as a temporary site? And their advice was no. Essentially, we're treating this like a home visit. We would need some additional insurance, but in terms of public liability, but we will get that separately. But in terms of individual medical indemnity, we've had confirmation, written confirmation from the Medical Defence Union that we are covered by our existing indemnity cover. And I should hope so. We bloody pay enough.
That's lovely. Thank you very much.
I believe that is the last of the questions that we've got through. Thank you, everybody that sent in questions. I hope this has been useful for you, but really my most gratitude goes to my good friend Mike for another exceptionally detailed, well put over webinar for networking health. And really what I would say is we will be sending out a questionnaire for you to all evaluate how we've done. And if you've got any questions for Mike, don't email the doctor. Please email us and we'll pass them over. Mel, anything else to add?
Yeah, just thank you to everyone that's joined in. I know a few people have had to leave early, so we are planning to, from Friday's session and this session, put an edited version together, so you can share that with colleagues and associates that weren't able to join us today, so they can get a bit of the background information that Mike's talked upon. I think particularly the relevant point that jumped out for me was around sort of CCGs and how that's going to shift more to PCNs. And as Mike said, that'll be a future webinar. I think he's just signed himself up for there. Thought I'd slip that in before he can escape. You can follow us on LinkedIn, so do spread the word about networking health, as I say, to your colleagues, and you can check out our website as well to find out more of the things that we'll be offering in the future. So yeah, thank you to everyone for participating today.
Thank you very much indeed. Take care.
Goodbye all.
Bye-bye.
Thank you.
Thank you.
Thanks a lot, guys. Cheers. That was great, Mike. Thanks.
Thank you.
Thanks, sir.
So just us.
Brilliant.
Cool.